Welcome to the EAUN podcast edition of EAU Podcast. In this EAUN podcast episode, we are delighted to be joined by Rikke Nygaard Knudsen and Susanne Vahr Lauridsen. Together, they will discuss the definition and prevalence of urinary tract infections, key prevention strategies, and relevant EAUN guideline recommendations, including the use of intermittent and indwelling catheterisation. Join us as we embark on this informative journey.
Welcome to this EAUN podcast. My name is Rikke Knudsen. I'm a member of the EAUN board and I'm excited to host this podcast regarding UTI. My guest today is Susanne Vahr, a very experienced nurse researcher with a long history in the EAUN. So please, Susanne, would you tell our listeners a little about yourself?
Thank you very much, Rikke, for inviting me to talk about UTIs in this podcast. And as you said, yes, I have a very long history in urology. I've been working for about 30 years in urology now. And since 2007, I have been part of the EAUN. I started in the guideline groups, looking into the catheterisation guidelines. And then I moved on and became a board member. And then I was chair of the EAUN board for some years. And in 2021, I stepped down. And now I'm back in the guideline groups.
And we are happy that you are back in that group because you have a great experience in this field. So, Susanne, you have a great experience in UTI. Can you briefly introduce us to the definition of an UTI, including the epidemiology and causes for developing an UTI?
Yes, if you look into the newest EAUA guidelines from 2025 on urological infections, you can see that they have introduced a new definition of the UTIs. And as you may now know, we have updated the indwelling catheter and the intermittent catheter guidelines in 24. So we have not incorporated the new definition yet. But in the EAUA guidelines, they distinguish between the localized UTI, that is cystitis, and this could be cystitis without any signs and symptoms of a systematic infection, and in both sexes. And it's important to remember that cystitis could be caused by bacteria, but it could also be caused by other things, because this is an inflammation of the bladder. So it could also be intravesical instillations giving people cystitis. It could be other medications that causes this inflammation. And the localized UTI is one thing. The other thing is a systemic UTI, and this means an infection with signs and symptoms of a systemic infection, and this could be with or without localized symptoms that comes from any site in the urinary tract, and again in both sexes. And just to make sure that everyone knows what the symptoms are, then if you look at the localized UTI, then the symptoms, or the typical symptoms are pain, burning, stinging when you have urination, that is dysuria. It's urgency, frequency, might be some incontinence, and there might also be some purulence from the urethra. And then you may have some pain over the bladder, but this is localized to the lower abdomen. And if you look at the symptoms of a systemic UTI, then you will see, in addition to the localized symptoms, there must be a fever or hypothermia, chill, shaking. People may have an altered cognition. There might be some delirium or confusion. There might be some hypotension, tachycardia, and also some people will present with costovertebral angle pain or tenderness. And it is very important that we distinguish between if it's a localized UTI or it's a systemic UTI, because the treatment will differ depending on what it is. And this means we come back to the assessment of the patient will be very important.
Yeah, and in relation to this assessment of the patient, what is the prevalence of a urinary tract infection between women and men? You already mentioned the definition is for both men and women, but why and how is the difference between these two?
If I should talk about urinary tract infections in general, then we know that in a lifetime, about 50 or 60% of all women will have at least one UTI, compared to about 12% of men that will experience a UTI at some point in their lives. And this risk in men will increase with age, especially due to the condition like prostate enlargement. And if you look in women, then they will also have an enhanced risk And the increased risk in women is due to the postmenopausal period, where there are less estrogen in the body, and this means that the bladder gets more vulnerable to infections. Besides that, the women have a very short urethra, which is placed close to the rectum, and this will also enhance the risk of infection from the E. coli bacteria. Women are about 4 to 5 times more likely to get an infection compared to men. And that is why it is important to explore the risk factors in both men and women before you start treating anything.
And about the risk factor, that leads us to the next question, because I know this question might spark different opinions, but the use of a dipstick, is it necessary to use a dipstick? Is there indication for use the dipstick in this assessment of the patient?
Mm-hmm. This is a very good question, Rikke, because this has been debated for very long. And if we look at the 2021 EAUA guidelines, they recommend not to screen, and that is use dipstick to treat asymptomatic bacteria. And this will often be the localized cystitis. They actually specify that the asymptomatic bacteria in the following conditions, that is women without risk factors, patients with well-regulated diabetes mellitus, postmenopausal women, elderly patients living in an institution, patients with dysfunctional or reconstructed lower urinary tracts, and patients with renal transplant. This is actually new. And also prior to some surgeries. And then also patients with recurrent urinary tract infections. And this group, I think, we need to pay a special attention to, because often when persons with recurrent urinary tract infections get frustrated, healthcare professionals get frustrated too. And then it is very likely that they will hand out antibiotics. And we know that this use of antibiotics will increase the risk of antibiotic resistance, and this will add on to the burden of death related to the antibiotic resistance. So it's very important that when we have people with recurrent urinary tract infections, that we try to rule out the risk factors. We send in a urine for culture and only prescribe antibiotics based on the answer from the urine culture.
And based on the symptoms the patient has as well.
Yes, but you need to have a positive urine culture and symptoms.
Yeah. And that leads to the next very discussed question about the catheter, bladder catheterisation and the development of a urinary tract infection, but also the treatment of these infections.
Yes, first of all, when you have an indwelling catheter, then you will bypass the body's normal urinary defenses, like regular flushing of the urine, which will flush out bacteria. The catheter can cause irritation or microtrauma to the urethra and also to the bladder lining, and this will increase the risk of infection. And the next, indwelling catheters will provide a direct pathway for bacteria to enter the bladder. And the catheter itself will enhance the possibility of biofilm formation. This is a layer of bacteria and proteins on the catheter, and this will protect the bacteria from antibiotics when a urinary tract infection with symptoms is treated. So this means that when you have an indwelling catheters, the risk of bacteria will increase, the risk of biofilm formation will increase, and the risk of a symptomatic infection will increase too. And this is why intermittent catheters should always be the first choice if possible.
And that's almost the answer of the next question, because could you provide some recommendation regarding the prevention of urinary tract infection, including relevant guidance from the EAUN guidelines? Example, use of intermittent catheterisation.
Because we know that the longer a catheter remains in place, the higher the risk of infection. So first of all, is it important to follow guidelines post-surgery? And when the catheter is supposed to be removed on day 1 after surgery, then it's important that nurses do so. We have good evidence that the use of stop orders almost cut half the risk of infections related to indwelling catheters. And these stop orders can both be electronically in the medical journal of the patient, or it could be nurses evaluating the need for the catheter daily. If renal function is not compromised, an intermittent catheter could also be considered. And still, despite all these interventions, a systematic review found that the UTA rates among intermittent catheter users range from 20 to 80%. So even when you turn to intermittent catheters, it's important that you educate patients or persons using an intermittent catheters on how to avoid urinary tract infections. In intermittent catheters, women seem to have a higher UTA rates compared to men when they use the intermittent catheter. And this is again largely due to the anatomical differences as described earlier, and also the hormonal factors. So if you want to prevent urinary tract infections in people with the indwelling catheter, then it's important to remove the catheter as soon as possible and use stop orders. In people using intermittent catheters, it's important to identify the risk factors, educate patients about what they could do themselves. And to this, you can use the UTI assessment tool, which we have described in the intermittent catheter guidelines, where you systematically assess the likelihood, the severity, and the risk factors of urinary tract infections. This tool will guide healthcare professionals to educate the user and also make sure that the patient perspective and the user's lifestyle is integrated. Some of the areas that are important to address is personal hygiene. It's a choice of catheter. It's a catheter technique when you insert the catheter. And it is also the type of catheterizer I mentioned. Because we know that evidence shows that the hydrophilic single-use catheters are those that pose the lowest risk of urinary tract infections to patients using an intermittent catheter.
So another important point I believe we should highlight from the guideline on indwelling catheters is the importance of replacing the catheter prior to collecting a urine sample and before starting treatment. Could you give some points about that?
Yes. If an indwelling catheter has been in place for 2 weeks or more before the symptoms or the onset of a catheter-associated urinary tract infection and the catheter is still needed, then the catheter should be replaced, and it should be replaced before you collect urine for urine culture. And this is because it will enhance the chance of getting a correct answer to the urine culture, and it will also lower the risk of bacteria remaining in the bladder due to the biofilm on the catheter.
So, Susanne, what are the main take-home messages of today's podcast to our listeners?
The main message will be that always assess your patient, identify risk factors, and avoid indwelling catheters if possible. Identify risk factors in people using intermittent catheters and use prevention strategies instead of antibiotics if possible to reduce the antibiotic resistance.
So very important take-home messages from Susanne. So thank you, Susanne, for sharing your knowledge and expertise. Remember to check out the EAUN website. It truly is a goldmine of resources on urology nursing with the guidelines as a particular jewel. Thank you for listening.
Thank you for this insightful episode. We are sure our listeners enjoyed it. To keep up with the latest EAU podcasts and stay informed on the urological advancements, be sure to subscribe to our EAU podcast channel on your favourite podcast app. Until next time, keep learning and stay inspired.